Welcome to Chapter 2 in Unit 2, where we're going to look at our first ethical principle, bioethical principle of informed consent. In this first lecture, we're going to take a little bit of a look in terms of back to our ethical theories. We're going to see that each of the bioethical principles that we'll be looking at in some ways are built upon some of the thinkers that we did in the first unit. So as we look at principles of autonomy and informed consent, we're going to really see the role of Immanuel Kant's philosophy here. So the principle of autonomy basically says that we shall not treat a patient without the informed consent of the patient or his or her lawful surrogate, except in narrowly defined emergencies. So that's what we're going to walk through here. Number one, how do we come to define and understand informed consent of the patient? Where are there cases where we need a surrogate? And how do we look at those narrowly defined emergencies in cases where we don't have informed consent? I want to note that this is both a legal and ethical demand. So while we're going to certainly look at the ethics of informed consent, it has been upheld since the 60s that healthcare professionals must require the informed consent of a patient before any procedures are done. We'll look at some of those dynamics. So just a few ethical questions as we look at the principle of informed consent. Number one, should we allow a competent patient to make an incompetent decision? What happens when we disagree with a particular healthcare choice? How do we define freedom and autonomy? We're going to see that sometimes coercion can be quite subtle. How do we protect those patients who are unable to make decisions on their own? Talking about the role of a surrogate. What does it mean to make sure that the patient has an informed consent? So we're going to, particularly in the next lecture, talk a little bit about ideas of informed and teaching and information. How do we look for issues of coercion? We'll see in this presentation that there are both explicit and implicit forms of coercion. And we just want to note that bioethics really rose in response to what has been called medical paternalism, that the idea of an informed consent and the role of the patient was not always the central principle in the practice of medicine. So we'll take a quick look at that. So as we turn to the role of Immanuel Kant, we're going to see that there are some key concepts in Kantian thought that are getting applied here. In our first unit, we talked a lot about how ethical theory is really based on views of human nature. So for Immanuel Kant, the role of reason and autonomy, logic and freedom are central to who we are. And therefore, Kant wanted to find a way that we could align our freedom of choice of actions and decisions with universal and rational rules. This is really an Enlightenment idea that eventually we'll be able to overcome all these differences of culture and religion and ideas and find a basis of universal principles based on reason. So what Kant's really looking to do in that deontological system is to make sure that we align our will with what he would call universal moral laws. And this is a little different than sometimes how we think about will. We think about a good will or a good intention. But what Kant's really trying to say is that we have to go through the process of making sure that our individual reasons for doing something, what he called our maxims, are aligned with these universal and rational principles, what he called categorical imperatives. So we're going to look at one particular formula of the categorical imperative, and this is called the humanity formula, because I think this captures what we're talking about in patient autonomy in the clearest way. Kant said that we must make sure that we act in such a way that we are to treat humanity, whether in our own persons or in others, always as an end and never simply as a means. So this is the idea that we're not going to use another person towards our own goal or initiative. And if we think about that applied, that could be problematic. So, the example of the taxi driver is sometimes given. If we're never to treat another human being as a means towards an end, could we never take a taxi? Could we never get in and ask the taxi driver to take us from point A to point B? Because we're using that person and that vehicle as a way to get to our destination. I should probably update this and talk about Uber more. I don't think taxis are going to be around much more. But to get back to our example, we can do this. And the reason that we can is that we recognize the autonomy of the driver. We sit down, we talk about where we want to go, there's an agreed upon price. We can allow the driver to say, sorry, I'm off duty, or no, I can't drive to that distance. That's all recognizing the choices that that driver has. So if we think about it, we often use other human beings as means, any type of service job where we're, providing a particular skill or service for another. But we must always recognize that that person is involved in making their own choice and determining their own outcome. So let's apply this to a patient autonomy and what we mean by informed consent. The consent part. The patient or an appropriate surrogate must be competent and have decision-making capacity to understand the consequences of the consent. So one of the things that's highlighted in your chapter is really understanding what the procedure is and what are some of the possible outcomes of the procedure. The informed part we're going to do in the next lecture is really making sure that the necessary information is supplied, I should say, and making sure that it's understood. It's going to be more than just presenting facts and information. So that level of competency and capacity to understand and agree upon or to reject is going to be the important aspects of informed consent. We're going to talk about those cases again where we have what is sometimes called diminished capacity of particular patients and the role of a surrogate. But for the most part, adults are consumed to be competent unless there's clear evidence to the contrary, and we'll talk more about that. So your book puts autonomy really in two ways, both really saying the same thing, but both in a negative and a positive sense. So consent means that there is no manipulation, persuasion, there's no coercion, that a person is freely choosing. And to put this negatively, we need to make sure that we don't act or we don't allow others to act with such authority and power as to coerce a patient into a decision. So these could be, particular threats or ultimatums from family members. If you don't do this procedure, you're not going to be welcomed home. Or, a doctor who says, I won't continue to treat you if you don't agree to this. But there's also even internally um, explicit coercion. We have to watch if the patient is under a particular treatment of drugs that's making them kind of foggy, or that there's a high fever that could be affecting it. So these are kind of both internal and external, but clearly explicit known factors. And for the most part, these should be clear and avoidable. To put this in a positive sense, a person should choose to act in ways that express her own sense of the good and the life plans that she might have for acting upon her free will. And here's where, ideally, ethically, we're going to try to help identify any implicit forms of coercion. This can include both fears of the illness or fears of procedures, or the opposite, really kind of a hope and some sort of magic cure that's really not there. And this needs to be really worked out through reflective conversations between the physician and the patient. Let's turn to the two provisions in our Code of Ethics, and we'll come back to these as we talk about informed consent. But if we looked at that first provision, we can see that there is a basic respect for human dignity, regardless of religion or culture. But I highlighted this right to self-determination, and I just want to read point 4 here, just a sentence. Patients have the moral and legal right to determine what will be done with and to their own person, to be given accurate, complete, understandable information in a manner that facilitates an informed decision, and be assisted with weighing the benefits, burdens, and available options in their treatment, including the choice of no treatment. So that seems to be a really clear case where your own nursing code of ethics is really honoring informed consent. In the second provision, again, there's a lot of different overlap, but I think that first principle, 2.1, nurses should provide patients with opportunity to participate in planning and implementing care and support that are acceptable to the patient. Honest discussions about available resources, treatment options, and capacity for self-care are essential. So those are just a few places, and maybe we'll keep coming back to some of these examples in the first two provisions of the code to see how they connect with our analysis of informed consent. So we're going to talk a little bit more next about informed, and we're also going to talk about some of these themes of surrogate and paternalism.